Welcome to the Pulse of Change. I'm Dr. Abdulelah Alhawsawi.
And I'm Dr. Azhar Ali.
Welcome to the Pulse of Change, the podcast where we explore the ideas and actions shaping the future of health and care. Today, we are joined by Professor Jason Leitch, one of the UK's leading voices in quality, safety, and system-wide improvement, from championing national safety programs to shaping Scotland's approach to reliability and harm reduction. Jason brings deep insight into what it takes to deliver safety at scale. In this episode, which is our first episode, we explore how improvement science, leadership, and culture come together to drive national transformation. So, Jason, welcome to the first podcast.
Well, thank you for having me. I'm either hugely privileged or maybe I'm just the guinea pig to see if you guys can do it. I'm not sure which of those, but I'm delighted to be here. Thank you for having me.
Thank you very much. So, how did your journey into change leadership begin?
Well, let's do the shortened version. I had a relatively conventional beginning. I was a dentist, so I graduated in Glasgow, where I'm sitting right now in the wind and the rain. You'll be delighted to know, in the west of Glasgow. Azhar knows it very well. I graduated in 1991. I know I don't look old enough, but then I trained as an oral surgeon. So lots of different specialties around the world that call themselves different things, but basically this part of the body: cancer, trauma, wisdom teeth. I did that for 15, 20 years, became a consultant, became an academic, did a doctorate. Pretty conventional trajectory. And then I had the privilege of going to the States. I went to the Institute for Healthcare Improvement as a fellow, funded, year away. Frankly, don't tell anybody, but frankly, I didn't really know who they were. I was kind of looking for a year off. And
Is that just a holiday, basically, you're looking for?
Well,
a paid holiday?
Yeah, well, maybe not quite a holiday, but somewhere in between a holiday and the work I was doing. So my wife and I went to Boston for a year, and it was transformational, literally transformational. I did a master's in public health when I was there, and I spent a year with this organization, this Institute for Healthcare Improvement, who still, I think, globally are one of the leading organizations doing system change. They adapted industrial methods from corporate industry and adapted it to systems in health and care. I then brought that home along with a host of others, and then we'll get into the conversation about what happened next. But that's the kind of transition point, Abdulelah. So there was a bit of a before IHI career, which was, let's call it average, lots of other people in that game. And then there's a post IHI career, which is a little bit more unique, I think.
So that basically that was the turning point, if you will, in your professional career.
I think so. I mean, if you'd asked me before I went to IHI, what was I going to do? I think I would probably have said, I'm going to be a professor of surgery. I'm going to be maybe the dean of the dental school in my wildest dreams one day before I retired. You know, I was on that kind of trajectory, whether I would have got anywhere near those things or not. I was working for the regulator on a national project. I mean, it was pretty conventional. And then IHI turned it on its head, not just professionally, but also intellectually. I got this new knowledge of, let me do it with story. So I would see the same people month after month after month with the same broken jaws, literally the repeat people coming with often the same injury. And IHI and the Harvard Public Health School completely switched my thinking towards public health and system change, rather than what others have coined as the repair shop, which we've all done, we can all do. Whether you're a GP, whether you're an emergency medicine doctor or a physiotherapist, you know what the repair shop is. And that has to be good, of course. But there is something else. There's something about preventing those injuries in the first place. There's something about the street where those injuries came from, the family where those injuries came, all of that. And that's what IHI and my public health training allowed me to do. And then I needed a vent for that when I came home, and the small container of consultant oral surgeon, that wasn't really going to do it. So something had to change.
So what happened after that then, Jason? You came back from lovely Boston to sunny Scotland. What happened then?
Well, I stayed a Red Sox fan. That was probably the most important thing that happened. And that is you can't quite see it, but that is a Red Sox jersey behind my head. For those just listening, the visuals will be lost on them. But so I stayed a baseball fan. And it was a slightly awkward period, if I'm honest, in my career. So I was, 2005-06. So I'm over 20 years qualified. I'm a consultant. I'm doing okay. I mean, it's fine. It's not bad. But I was constrained within my previous role. So I was running the 4th year dental class. I was the training director for the oral surgery trainees. I was carrying on with what I had done before. But then the government came along, and there's a kind of serendipitous moment where some of which is tragic, some of which is good. So the Scottish National Party won the election, as you'll remember well, in 2007. There was a national election in Scotland, and the Scottish National Party won. And most people, including the Scottish National Party, were a little surprised that they won. And Nicola Sturgeon became the health secretary. So she inherited a national health service, just a health service across the whole country. But she also inherited, let's call it a challenge or a scandal or whatever you want to call it, where there had been a number of deaths in a hospital near Glasgow. Over 30 elderly, mainly women, but not uniquely women, had died of a hospital-acquired infection. And it became a real scandal across Scotland, and rightly so. It was an infection that we had given them. I mean, we weren't unique in the world. It was happening all over the world, and we were getting more knowledge about why and what. So she inherited this. I had started to get small roles in government, helping with safety and helping bring IHI's methods, the organisation I'd worked with in the States, to Scotland. So we designed, I and a number of others, designed what became known as Scotland's response to that safety challenge. And lo and behold, unfortunately, if you design it, you then get offered the chance to implement it, which I should have run away from, of course, but I ran towards it. And I ended up as the national clinical lead for patient safety in around 2006-07, when I came back from IHI in the summer of 2006. And then I began with the government in the early part of 2007. And that was the beginnings of the Scottish Patient Safety Programme.
Great. So it sounds like there was a burning platform, which, obviously there was a response needed to that. So we talk, the purpose of this podcast is also to shine a light on things that drive transformation in a healthcare system. And so we're talking about safety specifically and safety at scale. So what does that mean? How did it move from a response to, these infections in a hospital to a national program? What was the driver behind that safety at scale? And what do you see by meaning by safety at scale?
Yeah, there's a lot in there, Azhar, and you were here at the time. You can remember some of that work, I'm sure, and from what from your perspective it felt like. When you look back now, from 2025 going into 2026, it's 20 years. So it feels slightly more linear than it felt at the time. History makes it smoother, doesn't it? So I think at the beginning, a number of things aligned. So there was very strong leadership from government. So there was a health secretary, Nicola Sturgeon, who subsequently became the First Minister of Scotland, the kind of equivalent of a Prime Minister of Scotland. So she was very keen and very driven to fix this and fix it publicly. So she was in the parliament saying she was going to fix this. My part, I think, was really bringing this IHI method and bringing IHI, who at that time were relatively unknown in Europe. They had done one piece of work across Europe and across the UK on a small scale, and that was very useful because we had a kind of prototype. So we had leadership, we had an organisation with the knowledge, not the healthcare knowledge, the system change knowledge. We had a kind of prototype, and in Scotland that was in Dundee, in the northeast of the country, where they had done quite a lot of this work. And then the next layer of leadership, unelected leadership, so Nicola Sturgeon elected by the population. The next layer of leadership was kind of the executive layer, if you want, the chief executives, the director general, those kind of people. And fortunately, the head of policy in the Scottish Health Department was my pal. And we had both been in America at the same time. He'd done a slightly different fellowship, but we'd met in America. So he came home back to his full-time government job. You know him, Azhar. His name is Derek Feely. And he was charged with finding this solution to this burning platform that we've just described in the Glasgow hospital. He looks to me. We form a partnership with IHI, and the rest will go on to describe what happened. If you were writing a book and needed a little bullet point list of what had driven that change, now when I look back, the burning platform was crucial for us. So there was something that attracted attention for sure. It was in the media. It was in the political mainstream conversation. There was definitely something about countrywide leadership. So they could have chosen to be distracted by the education service or the criminal justice system, of course. And they were doing those things at the same time, but there was a strong political focus. There was a strong leadership focus from the executive leadership. And then I think what IHI brought was a very strong method. So we had a technique. We had a new way of doing this change. And that became crucial because people had been trying to get rid of infections for years. People had been trying to do lots of without the success that was subsequently possible using these methods. So I think that would be my list: political leadership, burning platform,
Yep.
executive leadership, and method.
Yep. And when you say method, then can you say a bit more about that method? Then what was that method, and why the IHI method and not another method?
Yeah, so and IHI wouldn't like me calling it the IHI method. The man who started IHI is a relatively famous now pediatrician called Don Berwick, and he began it as a response to exactly these challenges that I've just described in Scotland, that also exist in Saudi Arabia, that exist in the Middle East, exist in America. And he would say that it's not an IHI method. IHI just packaged it in a way that health systems could kind of understand and use. At its core, at its absolute core, it is set an aim, measure the direction towards the aim, and then make changes that will drive that direction. Now that's a huge oversimplification of thesis's worth of method. But fundamentally, the core is set a direction and make it numeric if you can. So decide what you're going to do and announce it to the world. So we said we are going to reduce death in hospital by 20%. That's what we said. So we said Scotland will reduce its all-cause mortality by 20%. We also said we were going to reduce harm by 30%. So it was very clear what the aim was. What was slightly less clear at the time, if I'm totally honest, was how we were going to get there. But we can come to that. So then we said, how are we going to measure that? So we measured mortality. We measured all-cause mortality. We adjusted it. We used statistics to measure it. We measured all-cause harm, etc., etc. And then we had to find the answer to question number 3. And question number 3 in the method is, What are you going to do that will drive that change? And that's where you need the science, the evidence. This isn't guesswork. It's not. IHI's method is sometimes criticized as a bit woolly. It is exactly the opposite of woolly, because you need to take the very strong evidence that you've got from research, from the world, and apply that in a rigid, strategic way to the problem you then have. So in its core, that method is very, very simple. In reality, what you're asking is, well, in Scotland, nearly 200,000 employees, to take that technique and apply it to their location, to their operating theatre, to their pharmacy, to their dental practice, whatever that might be. Now, that is a thesis all of its own, how you do that human element of change. But the core scientific method is...
Sure. So you've described the methodology, you had this aim, you had that burning platform, the executive leadership. But how did that translate into, what we say, if we say safety at scale? So across, okay, Scotland's not a massive country, 5 million population, but still, a reasonable size. How did it translate into a national program? What were the key things that you had to do to spread that across the whole country? And what were the challenges in that?
So 5.5 million now. Since you left, we've got a bit bigger. So there's 5.5 million now. I think the fundamental answer to your question is by design. So we designed to spread. So there was never any suggestion that this wasn't going to all of our hospitals. Now, remember, we began in hospitals because that's where our burning platform was. We didn't stop there. And a decade later, we were in primary care, we were in mental health, we were in dental practices. But initially, this was a hospital-based program, an acute hospital-based program. And we designed it with IHI, with a vice president at IHI in charge of patient safety for them, a lady called Carol Harridan, who very tragically died this year of a recurrence of breast cancer. Far, far too young, but an astonishingly smart and intellectual woman, and a real force of nature, I would describe her as somebody who was very good at implementation. So she came to Scotland, along with some other smart people in Scotland and others, and we designed this thing. And it became known as the Scottish Patient Safety Programme. And it had 5 work streams. And very quickly, remember I described you need the evidence into practice. So we had evidence for 4 of these work streams. It was intensive care safety, operating theatre safety, ward safety, and medicines safety. So we knew kind of what to do in that space. So let's take intensive care as the example. I could equally take the other 3. In intensive care, we knew how to stop central line infections. We knew how to stop ventilator pneumonias. We knew how to do ward rounds. We knew how to do temperature for the patient. So there was a series of evidence-based changes to reduce harm in intensive care. That bundle, as it became known, was available. And we had one for medicines. We had one for wards, which included peripheral cannulas, included huddles in the mornings, a series of evidence-based changes. And we had one for operating theatres. Our 5th work stream, I think probably uniquely at the time, and from Don Berwick's brain, so Don said, I think you need a 5th work stream about leadership. And it was crucial. It became absolutely crucial. So it was less evidence-based because there is less evidence, but it was about engaging the senior leaders of each of our hospital systems in this program. So it was relatively easy to think how you would get an intensive care team to engage. It was more difficult than it looked, but it was you knew who they were. There was a doctor, a nurse, a thing. There was a team. And we spread it gradually to the 21 intensive care units in Scotland. So that trajectory is relatively straightforward. Hard to do, but straightforward to understand. The leaders was a little bit more tricky because they are distracted by 14 things every hour. There are financial challenges, there are demand challenges, there are, of course, safety challenges, which we were trying to address. So how do we get their attention? How do we get time with them and their time with their teams. So we created a leadership bundle, and that bundle made sure that they had to turn up, they had to have patient safety at their board meetings, they had to do leadership walkarounds about patient safety, and they had to report those measures into the big system. So we knew if the medical director was doing the ward round they were meant to do. We knew, and the minister knew, if the leadership bundle was being fulfilled. Now, we didn't yell at anybody, we didn't shout or do performance management. We just exposed the data. So we would have large meetings and we would say, this system has got its infections down by 5%, and the leaders have had 5 meetings with the teams. This system over here, the leaders haven't been showing up. They're not here today. So kind of exposing it rather than shouting at it. So those 5 bundles, work streams, whatever you want to call them, they were then what we spread around the nation. And we ran big, large, what in technical terms, if people want to look it up, is called a collaborative with a capital C, not just a collaboration, a collaborative with a capital C. That became the method by which we spread those 5 bits of work around all of the health system of Scotland.
So Jason, fascinating actually journey. Let's talk about accountability. I think this is very important. How did you at a national level, balance the improvement as a science, when you mentioned, evidence-based interventions with accountability? Where does accountability sit at a national level, and where does it become counterproductive?
Yeah, it's a crucial question, Abdullah. It's a really crucial question. And again, when I look back, I am able to describe it in a slightly more linear fashion than it felt at the time, if I'm honest. So I need to go back to the senior politician. So Nicola Sturgeon, whether you like her politics or don't like her politics, the woman is not scared. I think everybody would agree, even her deepest opponent would agree that she's not scared. So she stood up in Parliament and said, this is a problem and I take full responsibility for it. I am going to fix it. Now, I can then tell you that there was a room not far from the Parliament that I was in where she looked at me and a number of others and said, you have to fix this. So
pass the buck to
you. She took her level of responsibility, and I think that was really important. That was public. That's in the newspaper. That's in the Parliament. So she says, too many people are dying. There is too much harm. I am going to fix this.
Yep.
Now, of course, Nicola Sturgeon's got 5,000 things to do. She's not going to, but she did focus on patient safety. We had Patient Safety Week every quarter where she would do visits that were just patient safety visits. She would do speeches about patient safety. She always came to our big events and opened them and stayed and spoke to the teams. I spent a lot of time with her in the system. So we would go to intensive care units, we would go to wards, we would go to leadership meetings, and patient safety would be the mantra. So there was top level accountability. The next layer was in Scotland, Azhar will remember, because of our scale, and this needs adapted. So people need to adapt this for their context. If you're listening from Denmark, you will be able to transfer this relatively easily. If you're listening from Canada, this becomes a much harder translation because of the scale of the thing. Saudi Arabia, I think somewhere between those two extremes. We were able to get all of the medical directors in one room. There's only 14 of them. We could get all the chief executives in one room. There's 14 of them. So we were able to host events, meetings, and go to their regular meetings and say, put safety number 1 on the agenda. We want to come and talk to you about patient safety. And the medical, initially, everybody was kind of, we've got money at the top of the agenda, or we've got car parking at the top of the agenda, or we've got whatever it is we want to talk about. But gradually, patient safety became everybody's problem. And when we look back, it probably took 2 years for it really to become every board meeting, every senior leadership meeting talked about patient safety. And in those conversations, we were then gradually able to take data. We didn't have data on the first Tuesday. Of course we didn't. But after a year or two, we began to have comparative data between units. We began to have real celebration of units that had done very well. We had some more challenging places. Of course, not everybody went at the same pace. And we were able then to describe how it had worked in A and maybe not worked in B. And we were able to discuss that in the room. I remember there was a really, really important day of the chief executives meet monthly for a business meeting. They meet to discuss performance. They meet with the minister. They meet to describe how many ambulances are waiting, all of that. And for about 12 months, I had taken mortality data to that meeting. And I had presented the mortality data to them and said, this is your mortality data. Remember, the aim is a 20% reduction. That's where we're headed, blah, blah, blah. And I presented it anonymously. So I had the 21 hospitals along the x-axis, A, B, C, D, E, F, G, and I had the mortality up the y-axis. So I gave each chief executive everybody's data, but I only told each chief executive their letter. Do you understand? So am I describing that well enough? So they knew who they were, but they didn't know everybody else.
Yep. So you were exposing, but there was a degree of anonymity there. So.
Correct. About 18 months in, one of those chief executives who was not doing well, he was quite far down the table. He said in that meeting, for goodness sake, Jason, could you just tell me who everybody is? And I said, well, that's up to you guys. If you are comfortable with exposing everybody's data, I am very able to do that. And they all said yes. So that was a very important transition, because
that took a while.
It took a while. And you can understand why, because senior executives are used to being criticized for poor data, not supported through the poor data. These are two different things. I think it took them a while to trust me. It took them a while to trust that Sturgeon wouldn't fire them, but give them a chance. But what it allowed us to do was then take Hospital A and learn from Hospital F, or Hospital F learn from Hospital A, and we could begin to share what colloquially we call best practice. It's an awfully quick summary of complex systems. And it felt to me as though that was a very, very important turning point, where they were asking for their data, but everybody else's data to be exposed. And we were then able to unanonymize all of their data over time. It was very, very important. So that accountability then, Abdullah, to go back to your original question, what we were trying to do was make them accountable for their own systems. Now, at some level, Scotland pays £19.5 billion. There is a parliament. There is a health minister. Of course there is high-level accountability. Of course there is. The reality of system change is if the local leadership doesn't own it and doesn't feel it, then I think you will struggle. And that requires honesty. It requires transparency. It requires them to take responsibility for their own system. And to do that, you need to see your data. And that data should be comparative around the rest of your system. So that's where we ended up with the accountability.
I think that's great. Just to follow up, there's a saying that in God we trust. Everybody brings, their data. How did you make sure that, did you have an independent auditing, mechanism in place? So that's question number one. And question number two is, what was the kind of the full cycle of, what was the escalation process? So because it's not just about the mortality, which is very sensitive, data, especially for the public, that, these deaths were preventable, but it also, if you will, the leading indicators, you have these certain healthcare associated infections, So if a hospital A has higher rates of those healthcare-associated infections versus hospital B, uh, what was the escalating mechanism in place? How did you turn that into improvement, which all sounds like became sustainable improvement?
Yeah, so that was hard. So maybe we should do. We haven't actually described where we got to. Let me do that in 30 seconds. So after 10 years, we had a 19% reduction in mortality and a very significant reduction in harm that's difficult to quantify, but we had a 91% reduction in infections. 91%. So it took a long time, and that has been sustained. Even during COVID, those data have been sustained. So your question is absolutely crucial, particularly your one about escalation. So let me deal with your first one first, the data and our tendency to seek perfection rather than usefulness. So we could have set up we have the facility to set up an independent auditor. We have all that. That's available. And we have long-term data that comes into that system all the time. We chose not to use that for this purpose. This was improvement data, not performance data. So we allowed the systems to use their own data, and we trusted them to do so. Was the data always accurate? No, probably not. But over time, as people began to trust and people began to create a learning system in which they were keen to improve, because remember, the motivation for health and care workers, I don't question the motivation of those in the health and care system. There are a few bad apples, maybe, who would want to make their system look better than the rest. If you create the right culture, that they lose. Those who want to learn win. Because they want to reduce the infections in their population. They want their mums, their dads, their kids to have the best care possible. So it takes a little while. I'm making it sound straightforward. It's not straightforward. But over time, that improves. So we allowed them to hold their own data. We did insist that they reported it to us. So they sent it in. We had spreadsheets, and eventually we had fairly decent digital systems for reporting. And we would then put that into charts. We would put it into comparators so we could send it back. The second one about escalation is very interesting because the tendency of the centre where I was working was to make that into a league table and yell at the bottom. That was what had happened for 100 years. And it was quite difficult to hold that back. But again, Nicola Sturgeon, I said to her, I need time. This is not going to happen in a year. This is decades of harm, and it is the same all over the world. To do this properly, we need to give the systems time to adjust and change and spread the changes. If you start yelling, not personally, but if you start the yelling happening, then it's going to get worse. And she, to her great credit, I think, said, okay, but you have to tell them that we're coming to everybody. This is not optional. You can't choose not to do patient safety. What you can do is go at a pace that is appropriate for the spread from. So we have a hospital in Scotland with 3 beds, 1 ward, 3 beds on one of our islands, and we have a hospital with 1,500 beds in the centre of Glasgow. You can't hold those 2 hospitals accountable at the same time. That's ridiculous. So we had different timescales. But in the end, this is the game. You have to get rid of your Clostridium difficile infections. Now, how you do that, we're going to tell you. When you do that is a little bit negotiable because we're going to move from 1 ward to 4 wards to 40 wards to 400 wards. And that accountability, holding back that accountability was very important. Now, let me finish the answer with what happens if you don't get it. So we had the surgical checklist. The surgical checklist, relatively straightforward, but quite hard to implement. Is it the right patient? Is it the right operation? Is the x-ray up the right way round? Did they have their antibiotics on time? Who is in the operating theatre? Could you all say hello and what your job is? I mean, relatively straightforward. I've been a surgeon for 30 years. and operated with mysterious teams in the middle of the night who I haven't known and don't know their jobs or what they do. So that is transformational. I mean, it's literally transformational if you do it properly. And we had some surgeons who wouldn't do it, literally wouldn't do it. Yeah. And we had spread it across the whole country, and it had reduced surgical mortality. There's a very good publication in the British Journal of Surgery that suggests we reduced surgical mortality by about a third in Scotland in 4 years using the checklist. So in the end, the ones who wouldn't do it were sanctioned. So the Royal College of Surgeons calls them up and says, you've got to do that. You've got to do this, or you can't operate. Now, if you do that on day one, all you have is revolt and everybody throws their hands up in the air and it's chaos. If you do it after 3 years and you have to only do it to 3 people out of 5,000 people, then that's fair enough, because they're not doing what is now mainstream practice. But you have to create the mainstream practice on the journey. And we have a habit of trying to implement with laminated forms on day one that I haven't been involved in that. Why would I do your thing? Who are you coming to tell me what to do? Yeah. Actually, humans will change, but you have to tell them why, and you have to take them with you, and that's what we did. But I know there were 3 surgeons in the country who got a call from the president of the Royal College of Surgeons to say, you have to do the checklist. Because I told the Royal College of Surgeons president to phone them. Because if I had phoned them, they would continue to ignore me. But do you see what I mean? And if I had got the Royal College president to phone the 5,000 people on the first day, do you think that would have worked? Of course it wouldn't have worked.
So Jason, you said it was sustained. Sorry to interject. It was sustained, and I'm assuming that's based on the data, and a lot of the things that you're saying were contributed to that sustainability. But commonly, you find people talking about collaboratives across the world, and these have been run across the world, and whether it's on maternal health or safety here, and various other things, and they're quite resource intensive. So how do you actually move from, was it a shift from the collaborative methodology to something else where you actually led to that sustainability, embedding, as you said, just into normal practice? This is the way we should do things. And how did that happen?
I think you've just described how it happened there in that sentence, perhaps inadvertently. So much of the work became standard practice. So there's a very neat story to illustrate it. So the Chief Medical Officer of Scotland, a man called Sir Harry Burns, who had been the Chief Medical Officer during this whole process. Lovely, lovely man, a key mentor for me and for others. He goes in, he won't mind me telling you, he tells the story. He goes in to have his varicose veins done in a Scottish hospital. This is maybe 10 years into this process. And the young trainee doctor puts in his cannula. And he puts gloves on, washes his hands, puts the cannula in well, puts the dressing on properly, writes the date on the cannula. And so he does it in the way that the Scottish Patient Safety Programme has implemented. Now, Sir Harry knows that's the Scottish Patient Safety Programme because he's been involved and I've been shouting at him, and he's in the office beside me, poor man, for eight years. And he says to the trainee doctor, "That's fantastic. I'll need to tell Jason. That's the Scottish Patient Safety Programme." And this young doctor, who's just started, says, What are you talking about? Okay. And he says, "That thing, the cannula, the bundle. You've dated it. You're going to take it out." And he says, "I've no idea what you're talking about." And he says, "Who taught you? Who taught you to do cannulas?" And he said, "Well, in the last ward I was in, the charge nurse, the senior nurse in the ward, taught me to put cannulas in. I had learned the theory in medical school, but the charge nurse had taught me to put cannulas in, and this is how she taught me to do it. She told me always to write the date. She told me to take them out after 3 days if they're not being used and recite them. Now, does he need the Scottish Patient Safety Programme lanyard and the mug and the post? Of course he doesn't. Of course he doesn't. I think it's a wonderful story because
absolutely,
it's the embedding of evidence-based change into the undergraduate curriculum, into the trainees' training, and routine practice in that ward. The surgical checklist, you cannot have an operation in Scotland now without the surgical checklist being done. A nurse will stop the procedure if the surgical checklist is not being done. Now, some of it, a little bit trickier than that. So leadership walkarounds, board meetings having safety as their first item. I think some of that has slipped, Azhar, probably.
Okay.
But the care, I don't know if you and you've still got many friends here who are working in the system. I think Scotland's approach to safety and the culture was completely transformed in that decade. And quite a lot of that is hard to, I don't think that we're not done, but quite a lot of that is now hard to pull out if you wanted to,
Sure.
if you wanted to go back.
So if we were talking to leaders, globally, why should, and we're talking about healthcare transformation, why should they look at safety, and what would make it important for a leader to think about, especially when you've got stuff now, people talking about AI and genomics and technology, and why look at safety?
Well, I think it's the crucial underpinning of everything else we do. I mean, Hippocrates, how many thousands of years ago, said first do no harm. So healthcare is a more complex program of work than it was even when I qualified or when you qualified. It is harder, I think. Demand globally I was just in Saudi Arabia, and your demand numbers are as bad or as good as mine, if you want to look at it. I mean, our wonderful aging population is fantastic, but we've elongated life, but we haven't prevented disease. So that demand is now becoming overwhelming, and it's overwhelming here. It's overwhelming in your region too. I think safety is the most important thing you can then do to lead to efficiency, effectiveness, timeliness, all the other elements of quality. Quality is a huge subject. Do I want people to be kind? Of course I want people to be kind. Do I want the value for money to be efficient? Of course. But first of all, I want to know when my mum comes to your hospital, she's going to be safe. Then I, of course, want the correct care at the right time, delivered by the right people, and I'd quite like you to be nice to her. But in the end, my first priority is to not give her an infection and to be safe in that environment. So I'd rather she met a slightly grumpy Azhar Ali at 3 a.m. who was safe, rather than a lovely, joyous Abdulelah who wasn't safe. So it's not a choice, of course. You have to do all of it. But
it's a journey, isn't it?
Of
and
course,
that's a fundamental.
Of course.
But it's a fundamental component of healthcare.
But if you haven't got, if you're in Yemen or in India, and I've done a lot of work in India, if you're in a hospital in rural India, and you can't get the fundamentals of safety right, then it's hard to move from there. It's really hard to move from there.
So Jason, let me ask you this: while you're reflecting back on this amazing, program, which I highly recommend that you put in a book. If you did not think about writing a book, I would definitely. I would love for listeners and people actually watching this to have as many CEOs and leaders as possible. If a minister of health or a health system CEO asked you to start a national safety program tomorrow, what would be the top 3 things that you would insist to have in that safety program?
Well, what a privilege that conversation would be. That's a fantastic conversation to have, and you're very kind about the book. I think only you and my mother would read it. I'm not sure it would. I'm not sure anybody else would. But so the first,
I'll buy it and read it.
Yeah, you might read it. You probably know most of the stories, as are already. The first thing I would ask them is, are they sure? Are you sure? Because this has cost. This is not easy. This conversation has felt a bit like therapy, if I'm honest. It's great. It's a great joy to be able to talk through it. But it was hard work for hundreds and hundreds of people, and it took a lot of courage from political leaders and executive leaders inside the system. So I think the most important question you can ask is, are you sure? And if they say yes, and they mean it, then you can progress. Because that are you sure question makes them, that's a choice about resources. It's a choice about time. It's a choice about priorities, because every health minister in the world has a vaccination at the top of their agenda, has childhood obesity at the top of their agenda, has diabetes at the top. I mean, the agenda is a straight line of 1,000 priorities. So what you're asking them to do is say, out of all of those priorities, the most important thing we can do is safety within our health system for the population we serve. That's quite a courageous thing to do. So I think the most important question you can ask them is, are you sure? The second thing I would ask is, are you willing to take responsibility personally? So I think the Scottish story would suggest that at some level, now it depends on your country. In Saudi Arabia, you guys know so much more about your context than me. I think national would have some power in Saudi Arabia. National in the US, probably less power, because a lot of the healthcare is devolved to states, to regions, so you have to think about the structure of your nation. India couldn't do it nationally. India would have to do it statewide. Canada would have to do it at province level. So in Saudi and most Middle Eastern countries I've had the privilege of visiting and helping, I think probably could do something nationally. So the second question you ask the senior leader is, are you willing to take personal responsibility? And then the third question is trickier. This is fully unprepared. I hadn't thought of this answer. But the third question is, are you willing to give the system time to make these changes? And I think that's hard, because I've been with a lot of health ministers around the world, and they are impatient. And I completely understand why from their seat they are impatient. I understand it entirely, because they are either in an electoral cycle or a political cycle or a newspaper cycle or whatever cycle they happen to be in, where they will be held responsible quickly by their leaders or their people for the change. So it's a hard conversation to say to a health minister, you have to give the system time. If you two went to your health minister, I'm not coming with you, but if you two went and said, will you give us time? The obvious question from them is, okay, how long do you need and what will you do? So if you go, you have to have the courage to be able to say, we can do this for you, but we need your leadership and we need time. And that's what Nicola Sturgeon gave us in that first meeting when we went to see her. She did also, very importantly, ask me to tell her every week how it was going. So she got updates regularly, sometimes with almost no data, sometimes with very good data, sometimes with narrative and story. So it was important to keep her updated, for me to be held accountable, rightly, for what we were doing. But she courageously gave us time to make the changes.
Great.
I suppose, Jason, just reflecting on what you've said, the things that you've mentioned about what made up this journey, having an aim, the method, the leadership, I suppose that could equally be applied to a different channel. It's not just safety, but other. So in the region, people talk about, value-based healthcare and efficiency and, looking at sustainability. So those methods could equally be applied to another problem beyond safety.
Of course, Azhar, and we have done that with mixed success. So if you have an evidence-based package, let's call it, and willing people and ideas with which to make that evidence, I think it can be done. So we've done fantastic work in children's literacy and numeracy and physical activity. in Scotland schools using the same method. So I was asked to help inform and guide and lead some of that. Others, of course, did the work. Fantastic work in that space, led by some leaders in Scotland who have transformed the physical activity of kids. So you may have heard of the thing called the Daily Mile. The Daily Mile is kids run a mile every day just from their school. They just, in their normal clothes, just run a mile. And it's transformed physical activity in children. So there are things like that, literacy and numeracy. So that's a success. I've got others that weren't so successful. And I think looking back, the challenge has been the evidence-based package. So we tried to do a very similar piece of work around person-centered care, around kindness and people being person-centered and compassion. And it was fine. I mean, it wasn't bad. And it probably led to some change, but it didn't do what the safety program did. It didn't catch a light and change the culture of the nation. And I think it was probably because the evidence for what to do is harder to package. And the IHI method, the core method, needs that evidence-based package. Now, there are other ways of doing person-centered care. Of course there are. And we've started to do that. We're using digital tools. We're using other methods around feedback and all kinds of things to still do what we need to do around person-centered care. But the collaborative, capital C collaborative, didn't work as well for person-centered care as it did for patient safety.
Okay. So just to, as we move towards the end of this episode, maybe just if you could give us your kind of final thoughts, words of wisdom for the listeners, what would be this journey of 10 plus years, what would be the key message that you would give to listeners about safety and safety at scale?
I think the thing we haven't covered, probably, we've covered what you do at a national level. So in this fictional health ministers meeting, what would we do and what would we say? I think that's crucial. The reality is that most of the people listening to this will not be in the room with the health minister. They will be going to a community practice, they'll be going to a pharmacy, they'll be going to a ward or an operating theatre tomorrow and the day after. So patient safety does not have to be a national program. You, as an individual occupational therapist, doctor, healthcare manager, can influence patient safety in your context. Now, it may be that you have a national role, like you two, and it may be you can tackle this on a bigger scale and you can design a big that fantastic. I will be right behind you, about 100 yards behind you, letting you lead it. But if I'm in an operating theatre tomorrow and I'm the surgeon or I'm the anaesthetist or I'm the trainee, there are things I can do. I can do the checklist. You don't have to wait for permission. You can make sure that the care you're giving is as safe as it can be. You can learn the evidence around hospital-acquired infections so that your patients, when you are responsible for the cannula or responsible for the prescribing, you are making that as safe as it can be in the moment of care where you are responsible. You can also, of course, advocate for a larger program, for it to be included in training, and you should do that. But it's important to think about the microsystem care that you are doing each day or responsible for. You might be a manager in a ward, or you might be the chief executive of a hospital. You have power, small p power, to change it there. And then some people, looking at you two, of course, have a role where your context may be that you can say, I wonder if we should tackle this at a bigger scale. Should we do Riyadh? Should we do Jeddah? Should we do the whole country? What should we do? Yep. I think it's important to think about your own context and what you can do as well as what others can do. It's very easy to sit back and wait for the national program to come along and think you don't have any responsibility. That's not true.
That's great. I think that's really good to finish on, thinking about the individual level, but also the system level. And as you say, we don't all operate necessarily at the system level. And what we can do as individuals will make ultimately the difference at the system level. So thank you very much, Jason. Really inspirational story and very informative. I think is something that's really thoughtful and inspirational. The experience that you've delivered in Scotland. So we'll thanks for joining us. So we've had Professor Jason Leitch with us. So thank you for listening to The Pulse of Change. And if today's conversation with Professor Jason Leitch resonated with you, please follow and share the podcast. Join us next time as we continue exploring how leadership, improvement, and innovation are transforming health and care across the world. Thank you. See you next time. This is The Pulse of Change.
Conversations that move healthcare forward.